patient has, what kind of recovery, what kind of ongoing costs are due to the patient because of the delay in treatment or the misdiagnosis, and then what kind of pain or suffering the patient has endured. Unlike other countries, Qatar does have a penal code that apportions criminal liability in some cases, and that usually comes up in the context of a death by mistake due to negligence, where you may have failed to diagnose something timely and the patient subsequently dies. The courts do determine, however, that there is no liability where the provider acts in good faith in accordance with the standard of care. These are fact-specific issues. Sometimes when these issues become complex, the courts typically look to medical experts and will retain medical experts to review the medical record, talk to the providers, and talk to medically court-designated experts to form a more solid opinion in terms of what might have happened. So, that's the liability, that's the bad part, the liability, the law, the events leading to it. I'd like to turn now and focus on the preventative measures to minimize the risk of liability. And I think that the first and foremost, the most important one is communication. I think that, again, that what you say, how you say it, and when you say it, when engaging with a family and the patient, really forms the basis of the first impression, and it also helps you cognitively capture important information that you may not be able to see clinically with regard to the patient. I think that documentation is important, and then we'll talk a little bit about scope of care, and then I'd like to do a quick round of specific issues that come up typically when I'm the attorney on call in the legal department. So the first is communication. I gave you a good example of what I think was a sentinel case in the United States with regard to communication, where one simple word had so many different meanings. But even, again, understand medical vocabulary. Medical care has become increasingly complex, and the treatment regimens that we describe can be complicated, and so I would not hesitate to engage interpreter services to sit there and make sure that a patient is comfortable having a conversation in their own language and understands the medical condition that you're referring to. One of the challenges that we have sometimes is that family members may be well-meaning and have the best of intentions and want to do the translation. I strongly discourage that because I often find that the family will want to filter the information, especially if it's bad, not wanting the patient to suffer emotionally. And that's not necessarily in the best interest of the patient because, as you know, our goal is to tell patients what they have to hear, not what they want to hear. And then, again, I can't emphasize enough the utilization of translation services. That can be accomplished in person. It can also be accomplished over the phone. Technology has made this so easy now, and every institution has some degree of service available, and I heartily recommend it. In terms of communication, the other piece that I want to mention is clinician to clinician. With regard to physicians, I encourage a robust handoff. It would be like running a relay race and passing a baton. The physician who's oncoming in a shift in the emergency department should understand and have a pretty good understanding of what the patient's presented with, why they're there, and what investigations have been done thus far, and what has to happen next, so that they can step in and assume the continuity of care. Oftentimes, with regard to physicians and nurses may be a little reluctant to speak up. I encourage them to do so and repeat back verbal orders, medications, and critical test results to make sure that there's no mistake or misunderstanding about important information that needs to be relayed for purposes of patient safety. In terms of documentation, we often feel like we don't have enough time to do this, especially when we're really busy. We use the Cerner medical record, and I know at times that can be challenging. But I often recommend that you document as much information as possible. And as I say this, what I'm referring to is the fact that we need, at the very minimum, the trifecta of the patient history, why they've been there, how long has the pain been going on, where is it, what issues are associated with the pain, a review of systems that are pertinent to the chief complaint, the reason the patient's presenting there, any medications or any family history that's going to be helpful in forming an evaluation of the overall clinical picture, and then documentation regarding your medical decision making. What investigations are necessary, what tests, what's the appropriate disposition for this patient and why. And then narrative for any unusual events that come in. We've certainly had some unusual situations in CIDRA in just the few hundred days that we've been open where patients have been brought in, and they've often been brought in truly emergent circumstances where they've been unable to tell us what happened. And in such a case, you need to document. If the patient is brought in by the police department, simply state so. Be as chronological as you can so that we have a complete clinical picture of what happened, and we can tailor our care accordingly. Try to minimize verbal orders. And I know that that's easier said than done when you have a true emergency or trauma situation, but do try to do that and try to document as much as possible, again, so that there's no confusion. At CIDRA recently, we had a patient, actually a child, who went into cardiac arrest on a plane 20 minutes before the plane landed in Doha. And the child was brought straight away to CIDRA. It was met at the gate, thanks to Qatar Airways, with the ambulance and brought straight away. But by the time our pediatric intensive care unit admitted that child, they had already been through 4 different providers. A nurse who provided CPR on a plane, the ambulance personnel, our emergency department personnel, and then, of course, our PICU. And because we had good documentation, we had a fairly good clinical picture of what happened to that child and why, and how they ended up presenting into our PICU. Some of the things that I suggest that we not do in documentation, especially from a legal perspective when it comes to defending these claims, is to avoid unapproved abbreviations. I often find abbreviations and then I have to go back and figure out what they are, and if I can't figure it out, I know that it's hard for the clinician who's assuming care. So write in complete sentences and only use the approved abbreviations for your medical staff. Avoid jousting between clinicians and departments. If you're unhappy with the quality of service that your lab is providing in terms of providing critical lab results, they may be taxed and understaffed, or there may be issues that are beyond their control. So don't make an assumption that they're merely delaying the reporting of critical results because they don't care. There may be underlying factors. And jousting merely puts both of you in a bad light if we have to defend such a case later. And avoid personal opinions or labels. Be as objective as possible when you describe or document care and services. If you have a child who is presenting and you suspect child abuse, it's often best to, for example, document clinically, physically, objectively what you see so that you can be as objective as possible. And again, this facilitates continuity of care. So, scope of care. One of the issues that typically comes up a lot is consent. The issues that typically come up here are age. In Qatar, the age of majority is 18. So individuals 18 or over can consent to their care. However, in Qatar, women at age 16 are allowed to marry. If they present and they need care or their child needs care, 16-year-old married women can consent. Of course, the challenge then might be the maturity of the patient and the complexity of the medical decision. In such a situation, I often recommend that you engage the family to be part of the dialogue so that there's a better understanding of the treatment or procedures that need to be accomplished. And again, then one of the other issues is unaccompanied minors. We live in a country where domestic employees are common, and we discourage the use of domestic employees and getting consent from them. They are the least informed about a child's health and well-being, and so we always strive to use the parents. And then finally, again, language. Engage interpreter services whenever possible. These are the 4 specific issues that I think come up often, and so I'm going to do a lightning round. First is against medical advice. Studies have shown, both here in the Middle East and also in North America, it's the same common theme, but patients often leave against medical advice when they're either unhappy with the service, customer service, they feel like there's an unnecessary delay, or they don't like what you're saying. But what I mean by that is they're either overwhelmed with the diagnosis that you've given them, or they want a second opinion, or they just don't trust your judgment. In such a case, if a patient or their family is absolutely bent on leaving, I typically try to suggest that we treat it in 2 different situations. If it's a low-risk clinical situation, try to treat it as a discharge and at least facilitate follow-up so that you can see them and make sure that they're going to recover. If they're high risk, definitely try to encourage them to stay. But if they are absolutely intent on leaving, encourage them to seek care elsewhere. And if they come back, please don't treat it as punitive or blame them for the delay in care. At the end of the day, we're really here to treat patients, not be judgmental. Abandoned infants come up from time to time. They're brought in by the police, and this happens because sex outside of marriage in Qatar is illegal. Custody is with the police, and so when infants are brought to the emergency department, it's our job to treat them, evaluate them, stabilize them. If we have to admit them, we do. And then we, at CIDRA, we certainly engage our on-call and administrative team, and I'm certain that the Hamad has a very similar practice. And then we contact the police if it's brought by if they're not brought by the police, we contact the police and file the appropriate paperwork so that they can take custody of these children. Unwed mothers do come in. It's an ongoing issue. If someone presents in labor and they're unable to provide a marriage certificate, we treat the child, we treat the mother, and then we follow up through the appropriate administrative channels in terms of reporting, because it's simply an issue that we ourselves cannot deal with. And then finally, the other issue that does come up from time to time is unnatural death. There are 2 types of death for reporting purposes in the state of Qatar. There's the natural and the forensic. Forensic deaths arise when there's either a perception of criminal malfeasance or the death is for unknown reasons. If we cannot determine the cause of death through the normal testing or investigatory processes, we'll alert forensic police. When we do that, if the patient has expired, I always recommend that we leave the tubes in, we leave the IVs in so that the forensic police can do a complete investigation when they are accomplishing their mission. And then the natural death, we of course fill out the notification of death forms, and then we usually work with Hamad because they have the best relationship with all the embassies if we have to facilitate repatriation of remains. So the take-home message for me, I guess, to the CIDRA employees is we're here for you, and I would invite you to look at your Hamad colleagues and other legal colleagues as well. The earlier you engage your legal services, the more efficient and the more productive we can be in terms of helping you navigate these issues. We know that these issues don't come up during the course of ordinary business hours. In fact, I often joke they come up on Friday afternoon at 6 o'clock because that's when families are settling down and then they notice and decide to go to the emergency room. So we're here for you at any time, and we're available to answer any concerns that you might have. And with that, I'll take any questions.
Thank you, Julie, for that insightful talk. I would like next to you to take a seat there, okay? And also our other panelists, Dr. Ahmed Shamikh and Dr. Colin Powell, if all of you can come here. I think our app, Hello Crowd, is not working now. Is it? Okay. No questions.
Two.
So, but if you have any questions from the audience for our three speakers this morning, Colin will answer on behalf of the people who presented papers. Looks all of you are in a hurry to go home, is it? Oh, there is a question. Yeah, Sudhakar.
Testing.
Wonderful presentation. Thank you very much. It's not really a question, but a comment that I'm going to make about the sepsis paper that was presented. It was really good. I've been waiting for this kind of information for some time. I'm aware that in adult world, every hour of delay makes mortality rates higher. Last time I heard was it's about any delay about an hour or two, it's up to 5 to 10%, which is a significant jump. And there was no data like this from a pediatric point of view. The point I would like to make is there are institutions where the golden hour is not applied. They have 3 hours of time to complete the sepsis bundle. But within that as well, if I remember well, there is subgroup analysis. Those who got this sepsis bundle done within an hour had better outcomes than compared with those who have had sepsis bundle at the end of 3 hours. Do you have any comments on that?
Yeah, that's one of the questions that came through, so I presume it was from you. It said, where did this 1 hour come from rather than 3 hours? So first of all, in the paper, the 1 hour came from the New York Medical Board, or a New York state mandate with a reference. I've not looked where that's come from. But I think the most important data from this paper was the graph showing length of time and the crude mortality rate being at 5% at the beginning of the time. At 1 hour, it was just above 5%, and then you can see it slowly increasing up to 15% by hour 4. So the sooner the better, really, is the answer. And 1 hour, certainly with those 3 things rather than 6 things, simple things, blood culture, fluids, antibiotics within an hour, that's doable, and clearly this data shows an effect on mortality, which was the biggest surprise to me.
Can I ask a supplementary question? Sorry, it's a second one. How about any information about completing, including a lumbar puncture? Where is evidence or practice with regards to that in this golden hour times?
Just say that again, sorry, I missed that.
About lumbar puncture. LP.
LP for?
In completing sepsis care.
Oh, right. Well,
it's always a contentious issue. It's not there in this particular paper.
No, and in fact, in the care bundles for sepsis is not in there that I've seen in the literature. But there's certainly data about time to lumbar puncture and outcomes. There's no doubt about that for meningitis. I've seen that. Yeah.
Thank you.
My questions are very simple. They're all about consent. Can a child who is 15 years old and needs a minor procedure, can the consent be done by a 23, 24-year-old sister, or does it have to be parents?
So who would be consenting?
The child is 15 years old, needs a minor procedure. Can a 23, 24-year-old sister or brother can consent for him?
Legally, if the child is a minor, the parents have to consent. The law in Qatar, the Ministry of Public Health has made clear that age 18 is the age of majority, and so the parent or the person over 18 who's the legal guardian must consent.
Okay. Second question is that if a child is 16-year-old, he's been involved in a road traffic accident or something which he doesn't want his parents to know about and needs a minor procedure, will you go ahead with the procedure, or will you inform the parents, take consent from them, and then go for the procedure?
As much, the parent in me would say, of course not. And I have to say legally, and again, unless and until the child reaches the age of majority, for purposes of seeking medical treatment or procedures, the law recognizes that it has to be the parent. Now, I recognize that we have children with mental health issues. We have people who seek contraception guidance and other things, but we typically work with our social services department in terms of how we navigate those issues, but it's hard to treat without consent. Absent an emergency.
Okay. Last question. If parents are abroad or they are not able to come within the next few hours and we have to treat the child for a minor procedure, do we take consent over the phone?
In an emergency, we treat regardless of consent because the life is in peril and you do what's absolutely necessary to save the child's life.
It's a procedure which will improve the outcome but won't cause any damage if the procedure is not done. Like a small laceration. If you suture it, it will heal better, looks good afterwards. If you don't heal it.
If the parents, what I typically advise at Sidra, if it's not an emergent situation, and the child needs treatment, so a cut finger needs some stitches, and the parents are out of town, typically what I advise is that we call the parents and get telephone consent, and we document that we obtain that consent in the medical record.
Okay.
Thank you very much.
Mm-hmm.
Can I ask a fourth question for Jawad? Well, no, for Julie. Can an uncle, a blood uncle, sign consent for a child, say 16, that needs a procedure? So can an uncle within the family do that? Because I had that case the other day and someone told me within the law here they can. Is that right or not?
My understanding is only if the uncle is a legal guardian.
In absence of father, uncle is the next guardian, isn't it? In absence of father, uncle is the next to give consent. I think so.
Okay, the other part of that is what about, and this comes up not infrequently, the child is there with mom, there is no dad in the picture at all, and the 20-year-old brother of the patient, so the other son is really dictating, and the mother's like, I'm not signing consent, it's him. It's the brother who's over 18, there is no father. Because this has come up a number of times. These are such easy questions.
Well, consent isn't always it's always an issue because it contemplates the Sharia law and it contemplates the cultural values and standards that we have here. I strongly encourage that the mother sign the consent. I say that because that's what the Ministry of Public Health looks to, which licenses our facilities, and I look at the fact that that's the legal standard. If the son, the brother, wants to sign it as well, fine. But one parent at least should sign the consent form.
Or maybe they sign it together, at least you've got one mother's signature there.
If the mother, wants to have the brother in the room for purposes of making that informed decision, fine.
If mother gives that authority to the brother, she's there and she is asking brother to sign, we can document that, isn't it?
I would still have the mother sign the form.
Hi, my question is for Dr. Ahmad Shami. Since this is the influenza season and we see a lot of children coming in, presenting with fever, sore throat, no real runny nose, and we are confused between strep and influenza A and B. What's your take on doing influenza test on children who are presenting within 48 hours of illness, and if positive, treating each one of them with Tamiflu? That's the first question.
Okay, thank you for this question. That's why really I avoided talking about antiviral in my presentation. I mean, we do it even in Sidra a lot, okay? And most of the time, the children, they go home, and the second day, just to rank them, if they are fine, we are not prescribing them. But, I mean, there is a really clear guidelines, I mean, to treat the children from the Ministry of Health here. My take on this one, really, as a personal, I would say is I will not do it, okay? But the recommendation is still really you need to do it. And then if you want to do it, just do only for influenza A and B and the RSV. Don't go to the whole panel of the respiratory panel. So that's really my, I think if his child has underlying medical conditions, then yes. And especially if he doesn't really have the influenza vaccine, maybe it's a good practice to do it.
For all healthy children who have no risk factors?
Sorry?
My question was regarding healthy child who has no underlying risk factor.
I mean, as I said to you,